your orders with MRIs, probably the most common order indication you will see is what they call internal derangement. Internal derangement is a diagnosis that many insurance companies cover. They just can't put pain, right? Because, many times insurance companies will say, well, where's the pain at? Internal derangement covers a lot of knee problems, okay? It can be meniscal tears. It can be your cruciate ligament tears. It can be a bursa, because there's bursa in our knee joint. It can be a post-surgical issue. When you see the word internal derangement, it just means basically they have pain in the knee. It's then our job for the radiologist to figure out where. So when you are doing your MRI questionnaire to your patients, you actually have to tell them and write down, is the pain medial or lateral? Is it posterior or anterior? What kind of problems? Did they have an injury? What kind of an injury? Was it a skiing injury? Was it a gymnastics where maybe they were jumping? That, because of how our bodies are made, the history that we give doctors is an indication of, that's how that injury occurred. Was it a basketball injury and they pivoted and all of a sudden their knee gave out? It gives them an idea of what could be torn, right? You have the generalized pain, but many times you would probably see internal derangement prior to that. Any kind of bone tumors, bone damage, chondromalacia of the patella, you'll see that as an indication sometimes. That's just basically where your patella deteriorates, and a lot of runners, you might have that kind of problem, okay? Think about how many times as you're running, as that quadriceps tendon and the patellar tendon keeps moving and rubbing against that patellar bone, right? Okay, for the tib fib, the reasons that you would see would be any kind of a soft tissue injury, a muscle tear, bone or an infection, and again, stress fractures, okay? Setting up for the knee is pretty easy because we just put the knee into basically what looks like a small head coil, okay? We can scan left or right knees because we can slide it. We can slide the coil to the right, we can slide the coil to the left, depending on what knee you are setting up. The tib fib, we're going to use the same coil as we do the femur. We can try to get both joints in, but if you can't, again, get that closest joint. And we still, just like the femur, will scan bilateral femurs. We don't scan bilateral knees though, because we do one knee at a time, because we're using a smaller field of view for the knee. The knee coil, again, because we can get a coil around that knee, we're going to get better signal. So we scan our knees individually, but our lower legs and our femurs, we can scan bilaterally together, okay? And if you have a stress fracture in one tib fib, there is a high propensity you're going to have a stress fracture in that other one as well, okay?
I got a question.
Yeah.
For the knee coil that we have in there, is that a transceiver coil or is that a receive only?
That is it's a phased array coil, but it is a receive only. Our body coil will transmit it, but the knee coil receives it. But it is considered a phased array coil. Okay, parameters for the knee. When positioning for the knee, basically the radiologist wants to determine where that ACL is at. We want to see that ACL in one slice in that sagittal plane. Again, because the ACL in that right knee will kind of lay in our knee this way. In our left knee, it's going to lay in this way. So we don't position the knee straight. We do about a 5 to 10 externally rotated leg. And if you think about it, when you just naturally lay down, you naturally rotate that leg. That is more comfortable than trying to keep your toes pointed straight up, okay? So it's almost a natural way that we like to lay. If we can do that in this position here, we don't need to angle along that lateral condyle as much. Our angle isn't going to be as steep. And then we can hopefully get this image where we can see the insertion from the top to the bottom all in one image. This is our goal. We want to see that ACL. The ACL is more torn than the PCL. We want to see that ACL in one image. Okay, that is the goal. Will you always get it? No, because sometimes the ACL is torn. Okay? So what kind of protocols do we use for a knee? We always do a 3-plane. We'll do an axial. Many times we'll do a PD fat sat because again, what is the PD going to show us? That articular cartilage the best. Then we do T1 coronals, we can do PD sagittals, or maybe a T2 sagittal, and then we do coronals as well, okay? How do we set up? Pretty easy because we have an axial, a sagittal, and a coronal pilot. Then we just make sure on our sagittal plane, I can see my patella. I can see this quadriceps tendon. I can see my patellar tendon, and where it attaches, I know that's my tibial tuberosity. So I make sure I get slices above the patella, and then I make sure I get slices at least to that tibial tuberosity, and that's my axials. My field of view is going to basically be the size of field of view to the knee you're scanning. I talked to some of you last week about, I understand how for practicals, because it is nerve-wracking, you want to memorize numbers, okay? But it is good, and I understand that at the beginning that makes it easy to memorize, right? But hopefully, when we talk about field of view, let's start to not memorize field of view numbers. That's kind of the reason I was giving you field of view numbers, okay? I want you to start to think about, well, what field of view do I need that will cover that need? Because in real life, everybody's knee sizes are different. So don't memorize, oh, it should always be a 200 by 200. Because the next person, you might have to use a 270 by 270 because the knee's that big, okay? So, you know, try not to memorize field of view as much as try to think about, I just need to cover my anatomy. I need my field of view to cover the entire knee in this axial plane. Think about phase direction. If I'm doing an axial, what 2 directions of phase do I have? Okay, so what do you think that you would want? What phase direction? You can't be wrong.
Right to left.
You can do right to left. Now think about it though. What would be, even though you don't see it here, but what would be over here? Your other leg, yes. And that's why this is going to be dependent on the coil that you're utilizing wherever you're working at. There are some coils, because our knee, our left knee, let's say this is our right, is going to be right beside the coil, okay? Sometimes it'll try to pick up signal from that other knee. It's a receive coil, but both knees are really getting bombarded with RF. So therefore, the other knee is gonna try to go ahead and give off signal with the Larmor equation, right? Sometimes then this coil will pick up signal from the other knee. If you have a knee coil that's maybe only a receive, or transmit and receive, and it's only transmitting to this knee, then you don't have to worry maybe about that other knee getting into your image. So it's just one of those things where it depends on what coil you have and where you work at. You will scan a knee. If you go right to left, you might get some shadowing over this knee. You would need to turn on fold over, right? Even though I don't see it in this image, you might get signal from that other knee. And if you do, you have to understand, oh, that's why, okay? What I like about right to left, what Alex said is my popliteal artery and veins right here. You see these two little circles? And that's a lot of pulsating. So therefore, do I want my artifact here to go up and down, or do I want it to stay behind the knee? I kind of wanted to keep it behind the knee, right? If I would pick A to P, well, is there anything in the coil, anterior and posterior, that I have to worry about wrap? No. I can turn off fold over, and maybe that's what I want to do. But then I have to worry about this flow motion. But if I put a rest slab above and below, then any kind of flow coming down or any kind of flow coming up, you can maybe obliterate out, and you can get a nice looking picture A to P. It's your call. You tell me how you want to scan it, yeah.
So if you do right to left, you need fold over, and if you do A to P, you need the rest stops.
Yes. So you tell me how you want to scan it. Everybody might scan it a little bit differently. Yes.
So if we did have a transient flow, would we still need fold over, or could we turn that off in that case?
You could turn it off, but I'd have to look at the image. You know, I mean, I'd have to say, is there any kind of, because on patients that are really big, you might actually have this knee touching this coil. And so is it gonna try to get some of that signal? You know, it's hard to say. If you consistently can scan the knee and you never have any issue of wrap, then you don't ever have to turn it on. But you just have to look at your images. Yeah. Does that all make sense to you? Okay? So once we get our axials done, I'm going to page through these axials. So can you tell me, in this particular axial, where would be your lateral aspect? It's right over here, isn't it? See how that one is flattened and that one's rounded? Do you guys all see that? Because I don't want anybody to be confused. Once you see the flattened portion, that's going to be my lateral aspect. Then I just angle with it. This angle here should be about the exact same angle that your ACL is around your tunnel. Okay? And I know that my ACL is going to be in this area here. It's just that you can't always see that there because there might be a lot of fluid in the tunnel. You can't even see that ACL. But I know how to angle.
And the PCL is on there.
And the PCL will be on that side, yes. Yep, but she answered it for you, okay. So this is the angle that you are going to want to utilize when you're setting up your sagittals. You are going to angle your slices with the lateral condyle of the femur. Not this way, that would be with the medial, but this way. That's why you always have to be able to decipher what's lateral and what's medial. And if you have that leg in there externally rotated, your angle shouldn't be that steep. If you have it straight in there, then your angle might be more steep. that you have to utilize. There might be times that you don't even have to angle at all. Maybe even 5 degrees, depending on how much they lay that leg out. Okay?